Hello, good evening, everyone. Today I'm going to talk about post-dural puncture headache. Post-dural puncture headache is a major complication of neuroaxial anesthesia in obstetrics, as we are all aware. This can occur both following spinal anesthesia as well as inadvertent dural punctures during epidural techniques. So the objectives of our talk today is we'll dive a little bit into the background and the history of post-dural puncture headache. We'll review the pathophysiology and look at the presentation for post-dural puncture headache. We'll understand the risk factors and how they help us to reduce the incidence and severity of post-dural puncture headache, and we'll also try to understand the current evidence in prevention and treatment of post-dural puncture headache. So, post-dural puncture headache, it was first reported in the late 19th century by a German surgeon, Dr. August Beer. Beer had used himself as a subject to demonstrate spinal block. He was the first person to use a spinal cocaine to produce surgical anesthesia, following which he realized he experienced a disabling headache after the procedure. In his opinion, the headache occurred because of excessive loss of cerebrospinal fluid, which disappeared on lying flat, and he had the headache come back when he was sitting upright, which he presumed was post-dural puncture headache, and this was first published by him in 1898. So, pathophysiology of post-dural puncture headache. Obviously, as we are all aware, the CSF leaking from the dural puncture site leads to a loss of CSF fluid pressure around the spinal cord. And this causes a loss of buoyancy supporting the brain, which then the patient assuming the upright position, the brain starts to sag and cause tension on the meninges and the other pain sensitive intracranial structures, creating the pain sensation. We are also aware that the normal CSF pressure is in the range of 5 to 15 centimeters of water, but when we sit upright, um, can increase up to 40 centimeters of water, causing that gradient to increase that traction, causing stretching and further pain due to those pain structures. Having said that, it is not entirely because of CSF leak that the pain occurs during post-dural puncture headache. Much of the pain is not related to the CSF leak and is instead caused by vascular distension. As the body assumes that vertical position, this hydrostatic gradient across the brain increases, and there's more CSF exiting through the dural puncture. The body then attempts to compensate this by the loss of intracranial volume by vasodilation. And this process is reversed when the patient tries to return to the supine position, and hence the headache is relieved. So these are the images that show the difference in caliber of the blood vessel in a patient who presented with low pressure headache. So the first image is before, and the second one is after the blood patch. And as you can appreciate, the caliber of the blood vessels before the blood patch is dilated, and it becomes normal once the blood patch is done and the patient's headache is completely resolved. So coming over to the presentation for post-dural puncture headache is classically fronto-occipital headache and is often associated with neck stiffness. Sometimes the pain will radiate to both the temples, and patient might have discomfort behind the eyes. The pain is usually more diffuse than localized. The headache typically has a very postural element to it, and the pain gets exacerbated by sitting or standing position and gets alleviated by lying flat. The postural feature of the headache is, sorry, the postural feature of the headache with the pain is the main differentiating feature from other kind of headaches, such as subdural hematoma. Headache may be associated with other symptoms like nausea and vomiting, tinnitus, vertigo, or hearing loss, and sometimes there's visual disturbances such as diplopia and photophobia. If the CSF production rate is faster, the CSF loss is faster than the production. This leads to further reduction in the intracranial pressure and more downward traction, and sometimes it can cause traction on the cranial nerves, leading to especially the sixth cranial nerve. So, incidence of post-dural puncture headache is in the range of 1.5%, and more than half of these patients go on to develop post-dural puncture headache. Sorry, the incidence of dural puncture is 1.5, and about more than half go on to develop post-dural puncture headache. If you look at more recent studies, the incidence has shown to be even higher, and something in the range of 76 to 85% of patients post-dural puncture develop headaches. Onset: 90% of headaches will occur within the first 3 days of the procedure, and about two-thirds of these usually occur within the first 48 hours. However, this headache can develop as late as up to 14 days after the procedure. And very rarely it can even present immediately postpartum. Duration: most of these headaches will resolve spontaneously within a week, even if left untreated. And in minority of the patients, it can occasionally become chronic headaches. Diagnosis: the symptoms of postural headache and the history of dural puncture is usually sufficient to make a diagnosis of post-dural puncture headache. If in doubt, additional investigations such as MRI may be needed to confirm the clinical findings and rule out other serious causes of headache. The MRI scanning may demonstrate evidence of reduced CSF pressure. Myelography or thin sections of MRI or can be used to locate the source of CSF leak as well. Sometimes Doppler ultrasound can be useful in revealing the high flow velocity in the cerebral vessels in these patients with PDPH. We must always remain cognizant of the fact that there are multiple other causes of headache in the postpartum women, and we should look at other differential diagnoses and consider them as well. Risk factor: the inadvertent dural puncture and post-dural puncture headaches are avoidable complications. Therefore, as anesthesiologists, we need to be familiar with the risk factors and prevention. For patients whose dura is violated intentionally, say after a spinal anesthetic or a combined spinal epidural or even deliberate dural puncture techniques, the most important modifiable risk factor has to be to do with this needle selection. The smaller needles, say 24, 25 gauge, or pencil point needles like Whitaker and Sprout, have lower incidence of post-dural puncture headaches when compared to larger needles, 20 HKs, which have a cutting edge like Quinkes, where the incidence of headaches could be as high as 30 to 70%. The other risk factors which are associated with post-dural puncture headache is the gender. Pregnancy itself is a risk factor. Younger patients are more prone to these headaches, and history of prior headaches because of dural puncture. Now, the obstetric patients are considered high risk for postdural puncture headache, and not surprisingly because of their sex, their younger age group, and also the widespread use of neuroaxial blocks in these patients. So, we anesthesiologists have been active in attempting to reduce our incidence of post spinal headaches by reducing the size of our spinal needles. We today we are using smaller needles. However, we have to be aware that the apprehension over the lack of rapid appearance of CSF through the needle when you're using a smaller gauge needle may result in multiple attempts in a haste. Therefore, CSF leak through perhaps multiple unrecognized dural holes can result in postdural puncture headache after a apparently simple, uneventful spinal anesthetic. Apart from the size, the shape of the needles, the incidence is also inversely related to the experience of the anesthesiologist. We all notice an increased incidence in our PDPH rates around the time we have new residents rotating through our units. Another needle related factor that results in reduced incidence of PDPH is the orientation of the bevel, which they say should be parallel to the long axis of the spine, so that we are not cutting through the dural fibers and we're just separating them. And once the needle is withdrawn, that hole will close. The evidence for this is weak. The epidurals can be inserted with both loss of resistance of with saline or air technique. There's a lot of literature around that with pros and cons of both the techniques. There's some suggestion that using a continuous pressure on the syringe with saline may have an effect in moving the dura anteriorly as the needle approaches, thereby reducing the likelihood of dural puncture compared to the intermittent pressure technique with the air. In addition, inadvertent dural tap while using a loss of resistance with air may result in pneumocephalus, which could be another cause of headache. Once we have a dural puncture, unintentional, it is critical that in this event be recognized. These patients, at the least, be clearly informed about high risk of having a post-dural puncture headache, and they should be followed daily until discharge, or be called at home following discharge for about 48 hours or till the symptoms resolve. What additional measures can we adapt to reduce the risk of postdural puncture headache after unintentional dural puncture? This has been studied, and however, due to the lack of conclusive benefits of such interventions, we should always weigh carefully against the risk. One of the things suggested is a stylet replacement before pulling the needle out. Replacing the stylet is a simple and effective means of lowering the incidence of postdural puncture headache. Given its innocuous nature of this maneuver, there appears to be little reason why we should not be doing it. It does make sense to put the stylet back before you remove the needle. Limiting or avoiding pushing. So, in an event of unintentional dural puncture, limiting the duration of the second stage of labor, usually by, say, 30 or 60 minutes, or avoiding pushing at that time, can reduce the risk of PDPH. Although, if you look at the literature carefully, the evidence of this is again quite weak. And this is not a common practice in Canada. How about intrathecal catheters? This became popular a little while ago. Immediately placing a catheter when you get an unintentional dural puncture has an advantage of being able to readily provide spinal analgesia, as well as eliminate all the possibility of doing another accidental dural puncture in a challenging clinical scenario. However, the potential benefits of intrathecal catheter must be weighed against the readily appreciated risk, which is accidental use of these catheters or misuse, or even the risk of infection related to these catheters. The mechanism of benefit of intrathecal catheter is not very clearly understood, but it's believed to be because of reaction around the catheter or inflammation, which can cause the sealing and prevent further loss of CSF. There has been a meta-analysis which included 9 studies and which concluded that intrathecal catheter insertion following accidental dural puncture did not show any decrease in incidence of post-dural puncture headache. How about injecting saline? Again, there's limited evidence that indicates that if you inject intrathecal saline following an accidental dural puncture, this might be associated with a significant reduction of incidence of post-dural puncture headache. And the need for epidural blood patches may be decreased. This is thought to be by maintaining the CSF volume. However, the evidence is not strong, and we need to have further investigation into these before we make conclusive recommendations. Prophylactic epidural blood patches. Again, the systematic review published in the BJA showed that the role of therapeutic or prophylactic epidural blood patch for treating PDPH is inconclusive. When unintentional dural puncture occurs, there's several conservative therapies that are commonly used, such as hydration and bed rest. These methods are simple and do not have any serious side effects. However, the conclusive evidence is again lacking, particularly during the puerperium when you want these women to be up and about and ambulate to decrease their risk of DVTs and PEs. You don't want them to be tied to the bed. There has been a Cochrane review on this, which has again showed the evidence suggesting a routine bed rest after a dural puncture is not beneficial. And as also there's no evidence to support the benefit of prophylactic fluid supplementation after the post-dural puncture headache. What we do need to do is reassure these patients and use measures directed towards minimizing the symptoms, while we do not expect them to alter the natural course of the disease. However, it'll provide some relief to the patients. Other supportive management for symptom relief includes simple painkillers, non-steroidal anti-inflammatory drugs, or acetaminophen. Keeping yourself hydrated or avoiding dehydration is more useful than overhydration. Caffeinated drinks, again, has been popularly and continue to be used. Antiemetics and stool softeners should be prescribed when indicated. Abdominal binders have been advocated. Again, these are very uncomfortable and are very seldom used in modern day practice. Certain alternative measures like acupuncture or bilateral greater occipital nerve blocks have been described to provide symptomatic relief as temporizing measures before the epidural blood patches. There are several other prophylactic drugs that have been studied in their clinical effectiveness has not been established again. For example, epidural morphine or IV ACTH, which some studies have shown very promising effect in preventing PDPH after dural puncture. However, this is neither recommended nor routinely used because of limited evidence and the side effects. So, as we all know, epidural blood patches has emerged and remains a gold standard for treatment of postdural puncture headache. The first reported blood patch was suggested by Dr. Comley in 1960. How does the blood patch work? The postulated mechanism for action for epidural blood patch involves sealing the dural puncture site. MRI studies have found that this epidural blood adheres to the thecal sac, resulting in a clot formation, and this clot can be stabilized or remain there for about 18 to 24 hours sometimes. The pain relief is often rapid after the application of blood patches, and this we have noted in our day to day clinical practice as well. Although we don't expect the CSF volume to be restored immediately, how do these patients get immediate relief from epidural blood patch? This hypothesis, there is a hypothesis that the epidural injection of blood will increase the CSF pressure around the lumbar region, which will subsequently restore the intracranial CSF pressure and resulting in reflex cerebral vasoconstriction. And this possibly leads to relief of headache in the immediate period. What is the There's also some observational studies which have suggested that if you do blood patches too early in the first 24 to 48 hours, they might not be as effective. However, again, this evidence has to be weighed very, very critically because early onset of post-dural puncture headache likely to be more severe, and there could be a selection bias possibly, as well as if the epidural blood patches are performed too early, the clot degeneration may occur, or because of higher CSF flow, there might be displacement of the clot. So again, the evidence is there, and most of us prefer to wait the first 24 to 48 hours after the symptoms, managing patients conservatively before we do the blood patches. But however, this should be determined by the severity of the patient's symptoms. The optimal value or volume of the blood to be used has been studied extensively, ranging from 5 to 30 cc's. Peach et al. Had randomized 121 patients and studied three different volumes, 5, 20, and 30 cc's of autologous blood in patients, and they found very similar efficacy of epidural blood patch with the three volumes. However, subsequently, we've seen some studies which have compared 20 to 30 cc's, and they have shown that 30 cc's did not show any further benefit from the 20 cc's. So anything in the range of 15 to 20, 25 cc's would be optimal. There are some other pharmacological drug therapies which have been sorry. So, in conclusion, I would like to say that post-dural puncture headache is an entirely iatrogenic complication and of our neuroaxial techniques. The most effective method of decreasing the incidence to develop technique is to minimize the dural hole formation during the epidural spinals, and that to prevent any inadvertent dural puncture during the epidural blocks. We need to be better aware of the risk factors related with the post-dural puncture headache, and it is important for clinicians to be very vigilant when performing these procedures. Reviewing the literature, we know that although there are various prophylactic interventions after unintentional dural puncture, which have been studied extensively and suggest some benefit to preventing either post-dural puncture headaches or the need for epidural blood patches. But we are also aware that the evidence is insufficient and there is further research needed in this area. Thank you.